Hey everybody, Justin Dunaway here, and welcome to another episode of the PT on Ice Daily Show from the Institute of Clinical Excellence. Today I want to talk to you about spinal manipulation and migraines. I'm going to piggyback this talk off two new studies that have just come out recently in Cephalgia, which is a really nice journal if you're into kind of all things headache. But the first one is The Impact of Spinal Manipulation on Migraine Pain and Disability, Systematic Review and Meta-Analysis by Pamela Rist. And again, this came out in 2019. And the study was just a systematic review looking at the literature to look at studies that looked at pain, headache or migraine frequency, and migraine-related disability as it related to treatment with spinal manipulation, looked at against placebo, looked at against placebo manipulation, looked at other manual treatments, looked at against other passive treatments like medications or placebo medications, things like that. The first thing they talk about in the study is that nearly 38 million adults in the U.S. suffer from migraines. And I've been teaching spinal manipulation seminars across the country for about 7 years now. And when we hit this headache section, I always ask the room, raise your hand if you've never had a headache. And in 7 years of teaching this stuff, I've only ever met one person who's never had a headache. And there's some reports that say lifetime prevalence of any type of headache is something like 94%, right? So headaches are incredibly common. And migraine, tension type, cervicogenic headaches in general there's a beautiful subset of patients that would do really, really well with conservative management. And this just hasn't been a space that we've owned as physical therapists. So this is a space that's really interesting to me and one that we should all know more about. So anyway, back to the study. So they looked at studies related to pain, frequency of migraine attacks, and migraine-related disability as it related to manipulation. One thing that's important to point out is they were only able to find 6 studies that were done well enough for the meta-analysis. And after further review, they ended up pulling out one of them. The first 5 looked at just kind of all types of migraines. The 6th study looked only at chronic migraines, and they felt that they actually, in the chronic migraine group, they did really, really well with spinal manipulation, and they felt that the results were so skewed that they actually pulled that out and only looked at the first 5. So what they found is that that in all 5 trials, when we combined all the data, it was about 600 patients or so, they found that that there were effects on pain, and there were effects on pain or number of headache attacks, number of migraine attacks per week, per month in the spinal manipulation groups. And there was a smaller effect on migraine-related disability, but it wasn't quite as strong. So the study did show us that there was some value in it. However, as all systematic reviews and meta-analysis in our field show us, and I'm just going to read you the conclusion, is results from the preliminary meta-analysis suggest that spinal manipulation may reduce migraine days, pain intensity. However, variation in study quality makes it difficult to determine the magnitude of this effect. Right, so again, when we pool everything together, it just typically doesn't look as strong, and there's large heterogeneity in studies, there's risk of bias, there's lots of reasons why when we look at systematic reviews on a whole, things start to fall apart. But what this tells us, what this tells me at least, is that there may be some value here. There are definitely, in this cohort of 600 patients, there are patients that had benefit from a spinal manipulation treatment or series of treatments to the upper cervical spine. Now, one other study I want to look at before we dive into some of the things to think about around this. There's another one out of Cephalgia in 2019 from Bragato, and it was the presence of neck pain associated with more severe clinical presentation in patients with migraine. It's a cross-sectional study. They looked at about 142 consecutive migraine patients through the door. And again, the diagnosis of migraine is based off a series of points from the International Headache Society. And if you look at all these studies, they say that there's the International Headache Society criteria tends to get a lot of criticism. There tends to be a fair amount of overlap between groups. It's pretty easy to get pigeonholed in as a migraine or as a tension type headache. So realize that it's not, on the front end, it's not really a great diagnosis strategy anyway. So this is 142 consecutive patients through the door diagnosed as migraineurs with and without neck pain. The first thing I want you to see is that the patients that had migraines and neck pain had increased allodynia in their neck. They had decreased cervical range of motion, and they had decreased neck mobility. But whether you had neck pain or not, you tended to have the same amount of migraine-related disability. So the disability didn't seem to be affected by the neck pain, but there were some other things that cropped up if you had neck pain with your migraine. But where this study gets really interesting is this. Of the 142 patients consecutively through the door with the diagnosis code of migraine, 99 of them also had neck pain on board, and only 43 didn't. So first thing we see is that in a lot of these patients, there is some neck stuff on board. Now, when we look at this group, 67% of the patients with pain and 40% of the patients without pain all had reduced cervical mobility, diagnosed by the cranial flexion or the cervical flexion rotation test, right? Bring the patient into full flexion, maintain that flexion as you rotate left, as you rotate right. If you have a cutoff less than 32 degrees, it's highly indicative of cervicogenic headache, according to a lot of the other research. But what this study showed us is that most of the patients through the door had cervicogenic dysfunction from the cranial flexion rotation test. Also, 67% of the patients with pain and 40% of the patients without pain also failed their deep cervical flexion rotation test. So right off the bat, if a patient walks in the door with neck pain and headaches that fails their cervical flexion rotation test, and I can push on some stuff and they've got some pain in their neck, I can reproduce their headache, I'm pretty confident that we're going to make a difference through conservative management. Those are the home run patients right off the bat. Now, if we step to the side though, remember that 40% of the patients that had migraines but no neck pain at all also showed up with a positive cranial flexion rotation test, a positive deep cervical flexor endurance test failures, so the blood pressure cuff test. So they're also showing some of the same signs that we would see in our cervicogenic headache population. Right, so to me, this subset of patients may do really, really well with conservative management as well. There's some reports that say when we look at the whole of migraineurs, 91% of those patients are coming through the door with complaints of neck pain on board as well. The International Headache Society is going to tell us that 15 to 20% of all headaches are cervicogenic primary headache, or of all chronic and reoccurrent headaches are cervicogenic headaches, headaches that are driven through upper cervical dysfunction or dysfunction in cranial nerve 5 receptive fields. Why this is so important is that when we look at headaches in general, and there's a handful of studies that throw out stats anywhere from 50% to I've seen up to 80%. Of migraines that walk through the door, of headaches that walk through the door with a diagnosis of X, migraine, tension type, whatever, are actually misdiagnosed cervicogenic headaches. So there's a lot of value in taking these headache patients and putting them through a legitimate orthopedic exam to determine whether they may do well with conservative management. Why this is so important is that there are so many patients walking around with headaches that they've had for so long that they're taking some really nasty medications that really aren't making much difference in their life. That if they're responders to conservative management, they absolutely need to be in our door. So when we think about these headaches, when we think about migraines, are a lot of the migraines we're seeing or hearing about, are they actually migraines? Or are they misdiagnosed cervicogenic headaches? Or does it even really matter? When we step back and look at the whole of the symptomology and everything that's going on, it's pretty difficult to determine a specific subset of headaches based on clinical presentation and based on the story the patient gives us. Because when you start to ask patients questions about their headaches, one of the things we find is that there's just a lot of overlap. The stories that we get from the patients are pretty vague. It's hard for them to dial down on the exact symptoms to check the boxes in the International Headache Society criteria. And when they do check those boxes, there's a lot of overlap between pigeonholes. So maybe thinking about it that way doesn't even matter that much. What does matter, or what may matter, even if they're not a cervicogenic headache, according to that first study, we can see that there may be some value in throwing some treatment towards the upper cervical spine, because what they said it was a moderate to small effect size, depending on the studies that they looked at. But there was a change in pain and a change in number of headache disability days. Now, this is just looking at manipulation. So maybe there's some value at throwing some conservative management at patients with headaches if we can get access to them. Because if we can do this, if we can change pain, if we can change frequency of episodes, if we can change disability, if we can decrease the need for some of these medications that these patients are taking, there's a ton of value in that. There's a ton of value in reducing the risk of adverse events. There's a ton of value in removing patients' need for the healthcare system. There's a ton of patience in approaching patients and getting them on a more healthy, health-facing forward track. Now, when it comes to treating patients with headaches, when it comes to evaluating patients with headaches, just like everything else, there are some subtle nuances, and there's some specific things that we would look at and some specific tracks we can go down that would guide treatment. There's not time to talk about that in this little lecture, but what I do want to say is that if we're going to be in the space of treating patients with headaches, and we absolutely should be, there are tons of headaches, and that 38 million adults walking around right now that would do really, really well with conservative management. So we need to be in that space. But if we're going to be in that space, the first thing right off the bat is we have to be really, really familiar and comfortable with the vasculogenic symptoms, right? This internal carotid and vertebral artery stuff going on in there can give us some pain symptoms. They can give us some neurogenic symptoms, and we really need to have a very good, solid feel of risk factors and etiology and what that stuff looks like. Again, not enough time to talk about that here, but places to find that are Roger Carey, Alan Taylor, Hudding, Lucy Thomas. There's a nice iFOMP article by Rushton et al. There's a lot of really great resources to dive into the vasculogenic stuff to rule out those red flag headaches first. And then when they're not emergent headaches, diving in and getting a good detailed evaluation. But again, there may be some value in being comfortable touching your patient's neck, getting your hands on their upper cervical spine, provided a highly skilled, high velocity, low amplitude thrust manipulation of the upper cervical spine. There's some evidence to support that. If you're not comfortable with that, looking at some sustained natural apophyseal glide stuff or some mobilization with movement, but getting your hands on and getting the upper cervical spine moving, there's some value in that stuff. But as with all things, manipulation, manual therapy, mobilization, soft tissue work, whatever, is not the answer alone. It's never the answer alone. It's all part of the package. And when we're treating patients with headaches, yes, we need to get our hands on the necks, get things moving better, especially if we're seeing dysfunction in the cranial flexion rotation test, we're seeing weakness in the upper cervical, deep cervical flexor endurance muscles. But looking at progressive loading, getting patients on a program where they actually get their upper quarter stronger and more endurant, not just chin tuck stuff, but actually moving some weights, getting a deep dive into their lifestyle, diet, sleep hygiene, stress, rumination, adaptive versus maladaptive coping strategies. What do they do when they're having a headache? Do they go lay down in a dark corner and sleep, or do they get on the exercise bike and get their heart rate up a little bit? There's a lot of value in identifying how patients manage their symptoms and giving them adaptive and active strategies to do as their rescue medication. Instead of swallowing that pill as a rescue medication, do X instead. Looking at hydration status, looking at physical activity. All of this stuff becomes super important when we treat patients with headache pain. Headache pain are lifestyle patients. And yes, manual therapy, especially manipulation, seems to be really powerful in this population, but only if coupled with diving into their history, diving into their lifestyle, identifying where these dysfunctions exist, and then giving patients treatment strategies, graded exposure, goals around changing lifestyle things to move them into a more healthy, decreased headache type lifestyle. All right, I hope you enjoyed this talk. If you have any questions, please leave it in the show notes. I will be in Portland, Michigan in 2 weekends. So if you're interested in hearing more about headaches or learning how to do that upper cervical spine manipulation, that's where to find me. Or you can find any other dates for my courses or any ICE courses at www.ptonice.com. All right, everybody, have a great day, and thanks for listening.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.